So I'm going to switch gears here and I'll talk about some of the literature. So the first R I'm going to talk about is R, remove. We have already removed desflurane from our ORs. So this is a study done to see the impact of surgery on the global climate, a sort of a carbon footprinting of 3 different hospitals in 3 different countries. So John Radcliffe Hospital is in UK, University of Minnesota Medical Center in US, and Vancouver Hospital in Canada. All of them are tertiary hospitals. They have 21 to 24 operating rooms. John Radcliffe Hospital does around 30,000 cases. On the other hand, University of Minnesota does around 18,000 cases. But if you look at letter C, which is represented by John Radcliffe Hospital, only 4% of their emissions came from anesthetic gases because they removed desflurane from their ORs. However, 84% came from inefficient energy systems. They are not using renewable electricity, and maybe their energy systems are not retrofitted to the latest standards. So 84% of their carbon footprint actually came from there. On the other hand, if you look at B, which is University of Minnesota Medical Center, 51% of our emissions came from desflurane, and 36% came from, again, energy, because they are still not using 100% renewable electricity. So if you divide that by the number of cases, University of Minnesota Medical Center actually has the highest carbon footprint among all these 3 hospitals. Now, everything has a cost. So the global social cost of volatile anesthetic agents is actually determined by calculating the expected economic damage that is happening from carbon dioxide emissions. And they have given that number is $417 per ton of metric emissions of CO2. So if you apply the same analogy, desflurane, if used for 1 MAC for 1 hour at 2 liters fresh gas flow, will generate a social cost of $78, which could be 26 to 39 times higher than using CO or isoflurane, depending upon the fresh gas flows. In terms of auto emissions, using sevoflurane at 2 liters will generate the same emissions as somebody who drove 8 miles. Isoflurane at 1 liter, 7 and 189 miles for desflurane. So let me take a step back here. We have removed desflurane. Our electricity is 100% carbon neutral. These are the 2 best things that you can ever expect from a healthcare system. If we can nail down the nitrous oxide problem, we will have the cleanest department from anesthetic emissions, because we will take care of all the 3 problems, which are basically creating carbon emissions from the surgery. The second R I'm going to talk about is reduce. So besides choosing which anesthetic gas to use, all of us control at what fresh gas flows we are going to use it. And this study actually analyzed the kinetics and the consumption patterns of different approaches to sevoflurane delivery to maintain 2% end-tidal concentration. They basically compared 4 different strategies: 2 liters fresh gas flow, minimally or manually adjusted minimal fresh gas flow, which is roughly 300 cc's per minute. And they were comparing 2 different softwares, AGC 4.04 and AGC 4.07. AGC 4.07 is actually a latest software, and the big difference between these software is the latest software comes in 4 speed modes. Higher the speed, the less of the time it will take to reach that 2% end-tidal concentration or 1 MAC. And what they looked at is the consumption pattern of how much sevoflurane is being used, because it has direct environmental and financial benefits. So at 2 liters fresh gas flow, which is the commonest one, after 45 minutes, we consumed 14.5 cc's of sevoflurane. Comparing that with manually adjusted gas flows, we only consumed 5 cc's. Now, how many of us are comfortable using 300 cc's per minute fresh gas flows? I think probably less than 1% if I have to make a guess. So if you compare AGC 4.07 at speed 2, it only led to consumption of 6 cc's of sevoflurane. So in other words, 2 liters fresh gas flow actually led to 240% increase in our consumption of sevoflurane. Simply replacing our machines with this software, using it for 250 days a year, 8 hours a day, will lead to an annual savings of 17 liters of sevoflurane per year from each machine, which means we can reduce 9 metric tons of carbon dioxide emissions per machine. Now, the annual savings we will generate from this software upgrade will almost like 6,000 euros in terms of the sevoflurane reduction of consumption. The software in itself costs 5,000 euros. So the return of investment can be easily accomplished within 1 year. While we don't have a software like that, we really worked very hard to get a fresh gas flow alerts installed into our system. This is pretty much in the final stages, and hopefully we'll do a test run in the next coming months or so. Let's have a talk about the pharmaceutical waste. So, as I said, pharmaceutical is responsible for around 10 to 15% of the greenhouse gas emissions. Manufacturing of an active pharmaceutical compound is an extremely energy intensive, material intensive process in the chemical center because of the number of synthesis steps that you really require to produce a compound. And this study highlights the greenhouse gas emissions coming from the 20 most common anesthetic agents. The lowest one is succinylcholine, 11 kilograms carbon dioxide emissions per kilogram of succinylcholine to almost 3 metric tons of carbon dioxide emissions coming from Presidex. I'll be honest with you, after reading this article, I have a very high regard for Presidex. I'm not using it as often as I used to in the past. Most of the anesthetic gases, greenhouse gas emissions are less than 200 kilograms, almost 80% of the drugs. Unfortunately, there's a very poor correlation between molecular weight, complexity of the compound, or the number of synthesis steps with greenhouse gas emissions. Now, we all know that there's a significant amount of wastage that is happening in the operating rooms. Preparing these drugs is a time-consuming process, and it is a potential source of attention diversion from patient care. Because of the nature of the job we are in and the risk of error running so high, we land up preparing these drugs much in advance. And a lot of times when these drugs are not used, they'll end up getting wasted. A typical anesthesia department pharmacy budget is roughly around 10 to 15% of the total hospital pharmacy budget. So not only will it create environmental pollution, it also costs to the hospital because these drugs are getting wasted. So this study was done in Italy in 12 operating rooms, 12 institutions, including 2 academic centers, where they wanted to understand how much wastage is happening in their operating room setup. 2 of these hospitals are teaching hospitals. So before running the study, they actually did a pilot feasibility study for a month, and then of course extrapolated the data over a next year or so. They wanted to know how much time does it take to prepare these drugs. Now in this study, the drugs were prepared by the nursing staff, not by the anesthesiologist. They also looked at which are the most common wasted drugs. So the most common wasted drugs are 8% rocuronium, 16% was propofol. I would argue if we do the study in our setup, that will never be true. And 86% was epinephrine, 71% for atropine, with a median waste of around 38%. The amount of time spent on preparing these syringes on an average was 39 seconds. So in their pilot feasibility study, they collected the data on 13,000 syringes. And when they extrapolated it, they found around 139,000 syringes were actually wasted, costing them 78,000 euros or $92,000. I think in our setup, these numbers will be even higher. Now, if I look at it, propofol and rocuronium are only responsible for 8% or 16% of the waste. But if you look at in terms of the financial cost, they contributed to around 20% of the financial impact, meaning these drugs are far more expensive than the rest of the drug. So as I said, the amount of time they spent in preparing these drugs was 39 seconds. When they cumulatively applied, it led to the loss of 1,512 working hours of the healthcare providers to prepare these drugs. And by the way, these drugs generated 5 metric tons of waste alone, which also has an additional disposal cost of $12,000. This graph actually shows the impact of each component of the drugs. So for example, a drug like rocuronium, 86% of the drug is actually the cost of the drug, versus atropine, where 30% of the drug is actually the drug itself, and rest of the things are, the saline label, syringe, and disposals. One of the things I think COVID taught us is our resources are finite. They are not forever. And this is a graph showing the consumption pattern of different drugs prior to pandemic and after during the pandemic. So the consumption of propofol and cisatracurium actually went up almost by 100%. And we saw those supply chain issues. Presidex consumption went up by 211%, cisatracurium by 165%. Now, I recently completed a cell project about propofol waste. I said, what can we do about it? So propofol is the most common anesthetic we use. It's also the most wasted drug. Up to 60% of the propofol is wasted in our setup, almost 900 gallons. We procure around 1,500 gallons, and it's costing the institution almost $500,000. It is toxic to aquatic animals, and it, of course, generates greenhouse gas emissions. So we created a SMART goal. So first, we did a baseline audit. We actually did some survey about how much waste is happening, and we calculated the waste per case. So, and then we envisioned that by the end of our project, we want to cut down this waste by 50%. We sent a survey why this waste is happening in the first place. As expected, work pressure was the #1 reason for these wasteful practices. Absence of a standardized tool to determine how much propofol we actually need to use, along with easy access to large size bottles. There was also an inconsistent utilization of the syringe pump. We just came up with 3 interventions. #1, remove access to large size bottles. Create a calculator and tell, so that way we can tell how much propofol you actually need to use, and encourage everyone to use a syringe pump. So post-intervention, our data showed 34% to 61% reduction in 3 out of 4 locations. And that has an impact to generate potential savings of $300,000 and almost reducing the global greenhouse gas emissions almost by 2/3. And by the way, this is just one drug. If we start looking at neosynephrine, we start looking at nitroglycerin, those numbers can even be different. So there is a way to we can address pharmaceutical waste. I'm going to go to the next R, which is replace. Now we know that total intravenous anesthetic is the most environmental friendly option when we are comparing it with inhalation anesthetic gases. But what about with the use of vapor capture technology? So this study was done to compare 1 Mach hour of inhalational anesthetic gases, carbon emissions, with 1 Mach hour equivalent with propofol, utilizing propofol at 60 cc's per hour. So author ran 3 different scenarios. And before they do that, they said, okay, in vapor capture technology, the 2 presumptions we are going to make is we will only recycle the anesthetic once with the recycling ratio of 70%. Anesthetic gases are prepared by 2 different methodologies, method A and method B. Generally, method B is considered more advanced, generating less carbon emissions. And they also wanted to look at the fresh gas flow requirements of 2 different countries. For example, in UK, you can use sevoflurane at any fresh gas flows, even 2.5 liters fresh gas flows. But in US, you still use sevoflurane at 2 liters fresh gas flow. So in the scenario 1, they basically looked at using nitrous as a carrier gas and comparing all the different anesthetics. Scenario 2 and 3 is using oxygen air as a carrier gas and comparing all those numbers. So the graph, the diagram on the left is actually without the use of vapor capture technology. So we already know when sevoflurane, when desflurane was used as a, when nitrous oxide is used as a carrier gas in scenario 1, and we use desflurane, sevoriso, the impact of desflurane is the highest, no surprises. Even when we use oxygen air and desflurane, still desflurane is the highest. And of course, propofol impact was the lowest, as already known. And propofol generates around 1 kilogram carbon dioxide emissions per Mach hour. And out of that, half of it comes from the electricity we use to prepare those syringes. Now let's look at the graph on the right side when they use a vapor capture technology. So utilizing vapor capture technology in scenario 1, using nitrous oxide as a carrier gas, actually it led to the highest reduction in desflurane greenhouse gas emissions, and it even brought it down below sevoflurane prepared from method A. But when you look at scenario 2 and 3, the impact of greenhouse gas emission reduction was highest for sevo and iso. If we pay attention to scenario 3, utilizing fresh gas flows at half a liter per minute, utilizing vapor capture technology, utilizing method B to prepare sevoflurane, the impact of sevoflurane will be almost identical to propofol, generating 1 kilogram carbon dioxide emissions per Mach hour. We don't have a vapor capture technology yet available in our setup, number one. Number two, if we convert that electricity from disposable to renewable sources for preparing syringes of propofol, it will cut the emissions of propofol even further by half, making still total intravenous anesthetic the most environmental friendly choice. Now let's look about, should TIVA be used as an argument if there's a pregnant woman in the operating room? So there was a meta-analysis done by the authors, and they found that there is a higher prevalence of fetal loss among pediatric anesthesiologists than non-peds anesthesiologists. Scavenging systems can actually eliminate between 40 to 94% of these waste anesthetic gases. In a resource-limited country like India, having an investment is a huge ask if you want to have a scavenging system in every operating room. So the author is proposing maybe the new indication of using TIVA would be if there is a pregnant provider or a pregnant patient in the room, we should be considering using total intravenous anesthetic, especially when we don't have efficient scavenging systems. Now, I always believed that regional anesthesia is the most environmental friendly choice. This article actually changed my perspective a little bit. This study was done to evaluate the carbon footprinting of general, regional, and knee replacement and combined anesthetics for total knee replacement. The study is done in Australia, where the source of electricity is coal, not renewable. So the mean emissions coming from general anesthesia was around 14.9 kilograms emissions per case. Spinal was actually higher, 16.9, and the combined was even higher at 18.5. If you quantify it further, 20% of the emissions came from electricity. 25% of the emissions came from the use of single-use devices. Within spinal anesthesia, using fresh gas flows of more than 6 to 10 liters per minute led to 16% of greenhouse gas emissions, meaning oxygen is also not free in terms of a carbon footprint. Now, sevoflurane led to 35% of carbon emissions under general anesthesia and around 19% of carbon emissions in a combined approach. Even there is a regional difference. For example, if you do a spinal in EU, your carbon footprint is almost 60% less than doing a spinal in Australia. And the reason being because everything in EU is prepared from renewable sources. So your scope 2 as well as scope 3 emissions are significantly reduced.